So I think the reason co-op does work with cerebral palsy is because most tasks that we do have a motor piece to them. And we're all kind of aware of that. And as OTs, we talk about the sensory motor piece of it. So, you have to feel the cup, you have to get your hand around the cup. So we see this as a sensory motor activity, but it's also a cognitive activity, and it's also a learned activity. And so as OTs, what we've been focusing on is dealing with that sensory motor piece, but we don't deal with the cognition piece. So what co-op does is it brings cognition into the mix. And that's why it can work even with something like CP.
Let's be honest, many OT approaches introduced over the years have not held up to research scrutiny. But of those that have, there seems to be a uniting theme. In these approaches, clients set their own goals. Today, we are going to review an article about a pioneer of this client-centered process, the co-op approach. And yet again, we see the co-op approach outperforming conventional therapy, this time for children with cerebral palsy and spina bifida. After we review this article, we are so honored to have the founder of this approach, Helene J. Polatajko, PhD OT, to talk more about this research. I do want to note that in this episode, we are not teaching the full co-op approach, but you will learn really practical implications for goal setting and partnering with your clients. These lessons apply to working with people with cerebral palsy and many other population groups. I promise this is a conversation you don't want to miss. So let's dive in. Welcome to the OT Potential Podcast, where we review new and influential OT journal articles, then invite on an expert guest to help us pull out actionable takeaways that you can implement in your practice starting today. Welcome to the podcast. I'm your host, Sarah Lyon, OTRL. And before we dive into this topic of the co-op approach and cerebral palsy, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. As of this recording, it is just $89 to sign up for the club, so I highly encourage you to join us in there. And bearing in mind that this could count as a CEU course, I wanted to state our 2 learning objectives so you can be thinking about them throughout the podcast today. Our first learning objective is that you will be able to recognize the impact of children setting their own goals. Our second is you will be able to identify reflective questions you can utilize during treatment to encourage self-generated problem solving. So let's begin by looking at our journal article, and then we will bring on Helen to discuss how this research could play out in your practice. The article that we are looking at today is called The Cognitive Orientation to Daily Occupational Performance, or co-op approach, is superior to ordinary treatment for achievement of goals and transfer effects in children with cerebral palsy and spina bifida, a randomized controlled trial. This article comes to us from the Journal of Disability and Rehabilitation, and it was published in 2022. So the article begins with just this orientation to the co-op approach. Co-op stands for Cognitive Orientation to Daily Occupational Performance. The co-op approach is performance-based, task-specific, and goal-focused. It is rooted in a cognitive strategy that helps clients do their own trial and error-based problem solving to navigate their challenges. Clients are taught the simple and powerful strategy of goal, plan, do, check. Clients initially use this strategy to meet self-identified therapy goals. Then they can carry it forward beyond therapy to navigate future challenges. To learn more about this strategy, I definitely recommend not only reading the intro of the full article, but also perusing the co-op website. And I do want to mention there is a track to become a fully certified co-op therapist. So does this co-op approach work? The co-op approach has shown promising evidence of a treatment effect in persons of different ages and diagnoses, including adults with stroke and children with developmental coordination disorders. There is emerging evidence on the effectiveness of co-op in working with autistic children and children with cerebral palsy. Co-op has also been shown as feasible for adolescents and young adults in a Swedish context. Given its feasibility, it is crucial to investigate co-op's effectiveness, which leads us to this paper. So what was the intent of this research article? The aim of this paper was to investigate the effectiveness of the co-op approach in children and adolescents with cerebral palsy and spina bifida. Specifically, the authors sought to explore co-op's effectiveness in comparison to conventional rehab with respect to success in achieving self-identified goals and generalization and transfer effects. So what were their methods? This was a randomized controlled trial. The intervention took place in a real-life Swedish environment where children with disabilities can register with a rehabilitationist center in their region. Looking at the participants, to be included, participants had to be 8 to 16 years old and have a diagnosis of cerebral palsy or spina bifida. They had to have challenges performing or organizing activities and follow the mainstream curriculum at compulsory school. They had to be able to formulate their own goals and be able to communicate verbally in Swedish. Looking at the assessments that were utilized, the following assessments were utilized for baseline and follow-up measures. For the primary outcome measures, they used the Canadian Occupational Performance Measure, or the COPM. They used this to have the children set 4 goals, and 1 goal was purposefully left untrained to enable the study of generalization and transfer. They also used the Performance Quality and Rating Scale, or the PQRS. It provides an observable scale and was designed for the co-op approach. In this study, the children's performance of each goal activity was documented by video and rated by a certified co-op therapist using this PQRS. For their secondary outcome measures, they utilized the Child Occupational Self-Assessment, or the COSA. This was used in a structured interview about 25 items related to everyday occupations. And this assessment was used to study transfer effects. And lastly, they used the Dellis-Kaplan Executive Function System. And this was used to assess executive abilities and was used to investigate whether the intervention had any impact on those abilities. So what did the intervention actually look like? The co-op approach was applied over 11 sessions conducted once per week, each lasting 45 to 60 minutes. Most sessions occurred in the child's usual environment. In the initial session, the therapist introduced the child to goal plan, do check, which the therapist then used consistently when working with the child to achieve their goals. The therapist guided the child in discovering their own plan for performance, and the child implemented the plan and checked whether it worked or needed to be modified. Work was focused on a single goal, and once that goal was met, the second and third goals were progressively added. Looking at treatment as usual, the children in this group had their regular ongoing contact with the team at the Regional Rehabilitation Center. The services there are family-centered, and the treating OTs received information that the child had formulated 4 goals using the COPM, but they were not informed of the nature of those goals. So the big question, what were the results? 38 children participated in this study, and the goals chosen by the children fell into the following categories: preparing meals, self-care, home life, organization of school and homework, leisure, orienting oneself to one's environment, and societal life. Per the COPM, self-rated goal attainment was significantly higher in the co-op group for both trained and untrained goals. The scores on the PQRS were also significantly higher for trained goals in the co-op group. Per the COSA, the co-op group experienced fewer problems in everyday life after treatment. However, it's interesting to note that both groups did note a reduction. Per the executive function assessment, executive function did not vary significantly between groups. So lastly, headed into the discussion, the co-op group showed higher goal achievement for trained goals in both subjective and objective ratings. The effect sizes were moderate, bordering on large. A generalization/transfer effect was also seen in subjective ratings of untrained goals. The authors note that transfer is a crucial part of the rehab process, but it is rarely an outcome of rehabilitation interventions. One interesting finding, both groups perceived that they had fewer problems in everyday life during the follow-up interview. One possible interpretation is that both groups experienced an effect simply from setting their own goals, perhaps being treated as capable of discussing their individual challenges and what is important to them, and then being trusted as capable of working towards self-identified goals made an impact for these children. And one more important note, the study showed no measurable improvement in executive function. This may be because executive function measures are not sensitive enough to reflect improvements in everyday performance. But with our current knowledge, it seems to confirm the suggestion made by the International Classification of Functioning and Health, or the ICF, that an intervention does not necessarily have to affect body functions in order to improve activity and participation. The author's final conclusion: for children with cerebral palsy or spina bifida, the co-op approach is more effective than ordinary treatment in achieving both trained and untrained goals. This was such an awesome paper, and it sparked so many questions for me, both about this specific research, but also about our clients setting their own goals, this focus on performance, and how this approach even came to be. And that is why I'm so thankful to be welcoming our guest, Dr. Polatajko. Helen is an internationally respected occupational therapy scholar and teacher, and a valued mentor. She has well over 300 publications, has done over 550 presentations in more than 20 countries, and has held over $10 million in grants. Her work has focused on occupation and its enablement. Prominent among her contributions are co-authorship of the internationally acclaimed Canadian Occupational Performance Measure and the Enabling Occupation books, and leading the creation and development of the Cognitive Orientation to Daily Occupational Performance approach. Dr. Polatajko has been granted numerous top awards and distinctions, including the Muriel Driver Lectureship, election to the American Occupational Therapy Foundation's Academy of Research, and being named as a fellow to the Canadian Academy of Health Sciences. As a financial disclosure, I do want to note that Helen does receive nominal financial compensation related to the co-op course in the form of royalties from her books and for speaker fees. However, the course itself is administered and overseen by a nonprofit called ICANN. So without further ado, I'm so excited to patch Helen into this podcast. Welcome to the podcast, Helen. It's great to have you.
Well, thank you so much for inviting me, Sarah. It's such a wonderful thing that you do this. It's such an important thing for our profession. So congratulations. I'm happy to be part of it.
I am so excited to talk to you today. I have to tell you, this weekend, I was listening to a podcast on the neuroscience of goal setting. And right away, they said 4 things about goal setting. They said, you need to set your own goals. Someone can't set them for you. You should work on one goal at a time. And your goal needs to be lofty enough that there's some difficulty in achieving it, that you need to do some trial and error, because that challenge is what triggers our neuroplasticity and actually makes us change. If it's too easy, that's not going to happen. And I am like, how in the world did Helen know to embed all these things in the co-op approach? This was not what I was taught in OT school. So if you could just start us with the story of how this approach was born.
So first of all, in terms of goal setting and the effect that goal setting has, and you're quite right, it's super, super important to organize the brain. And all of the stuff in neuroplasticity says that, right? So like one of the worst things you can do, and we've seen people do this, including OTs, is sit down and have somebody practice something. My favorite example of what not to do is cone stacking, where they have this for people who are recovering from stroke, and they sit at this table, 4 or 5 people at a table, and they're all sitting there stacking cones. That does nothing at all, and it doesn't even change the neuroplasticity. So if you want to change neuroplasticity, which is what learning is, which is what skill learning is or skill acquisition is neuroplasticity. If you want to make that happen, it has to be focused, and the way to focus it is initially through goal setting, and then of course the other way to focus it is through problem solving. Yeah, so it's retrospective, but it's interesting as time has evolved, because we've done co-op for a while now, or created it a while back. As time has evolved, more and more of the neuroplasticity research is demonstrating that the key ingredients for neuroplasticity, for making neuroplasticity happen to be the key ingredients of co-op. So it's not that I'm smart, it's just that I had been working from a behavioral perspective for a very, very long time, and from a learning paradigm for a very, very long time. And we all know, the horse to water thing. We all know, unless you want to learn something. One of the things I often do when I do co-op workshops, depending on the country I'm in, I say, so how many of you went to piano lessons all your life? Not all your life, but how many of you were sent to piano lessons by your parents? And half the audience probably puts up their hand. And then I say, and how many of you play piano now? And if one or two people put up their hands, it's a lot. So that's exactly the point, right? If you're forced to do something, unless you're somehow in the process of being forced to do it, develop a real interest in it, it's not going to happen.
So back in the day, were you trying the elements of the co-op approach in your practice and seeing that they worked? Were you reading about these concepts? How did this come together? It feels so pioneering and trailblazing. What spurred it?
So none of that happened. What spurred it was I had done my PhD looking at some of the basic hypotheses underlying sensory integration. And that didn't turn out very well in terms of my findings didn't do what I had hoped they would do. And I got sort of the null hypothesis, which if you're doing a PhD, the last thing you ever want is a null hypothesis. They're very, very difficult to defend. At any rate, but just because the hypothesis didn't work doesn't mean the intervention doesn't work, right? So, for example, people have been doing, electrostimulation of brains, EEGs or not EEGs, ECTs for years and years and years, and we know they work, but nobody ever knows how or why, but we know that they work. So just because something we don't understand why it works doesn't mean it doesn't work. So I set out to do research on sensory integration, and it was not good. The research was good, but the results weren't good. And then I set out to do research on different aspects of how to help kids with motor-based learning problems, kids with DCD. At the time, they were referred to strictly as learning disabled kids. And every piece of research I did, probably for the first, 4 or 5 years of my career, always the hypothesis was not substantiated. I always had the null. So there was never a treatment effect that was different from either placebo or some other supposed to be, or actually even control group, no treatment. So I got very frustrated. And I remember standing in the corridor between my lab and my office and saying to my research assistant, this is crazy. These kids have a normal IQ. Often they're quite intelligent, right? A lot of LD kids had high IQs. And I know I used to work with kids with severe mental retardation, or as we called it at the time, intellectual handicaps. So they, people with IQs of 20 or less. And I know I can teach those people skills. I could teach those people how to write a letter, like the letter A or whatever. I don't understand how we can't teach a kid with DCD with an IQ of 120 or better how to write the letter A. That just doesn't make any sense to me. So you know what? We're going to drop all this and we're going to go to a behavioral approach. But because these kids are bright, average intelligence or better often, we're going to use a cognitive behavioral approach because we want to harness the cognition that they have. We want to harness those cognitive skills. So that's what we decided. We would try out a cognitive approach to address motor problems. And lo and behold, it worked. It's been working ever since.
Wow. That resonates with me so deeply, thinking as a clinician where there are definitely times, especially early in my career, where I would see people and just have this sinking feeling of like, this isn't helping. And I think that is an experience that probably a lot of OTs have felt. So that's interesting that you had that in the research context, but were able to push through to the next idea.
That's what research is supposed to do, right? Research is supposed to learn from its findings and move forward. So I was just doing what a researcher should. The approach was only created within a research setting. And it wasn't until we had, the original studies, which were a study plus 10 replications of that particular study, and then more replications of it because it had always been the same therapist. And that therapist is an incredible, like she is, or is, I guess. She's not dead or anything. She just doesn't do OT anymore. But that therapist was an incredible therapist. So then the next question became, well, can anybody do this? Or do you have to be, do you have to have the magic hands of Anne? Like we know there's some approaches where the clinician walks in and does the laying on of the hands and these magic things happen. And then you try and do the same laying on of the hands and it just doesn't happen for you. So the question was, is it this person who's able to do this, who has some special touch or something, or can we replicate? So that became our next question. And once we saw that we could replicate it, then we decided to do a pilot randomized trial. So still not going public with any information about the approach. We did a randomized trial, pilot trial, and the results were amazing. And that's when we started to tell other people about it and try to teach other people to do it.
And then what amazes me about the co-op approach is how much it's been studied and with so many populations. I'd love to hear the story of how that happened as well. And also if you've had surprises over the years and how the research has borne out.
Well, I think the fact that the research has borne out is in and of itself a surprise. I certainly didn't expect that. The way it happened initially, and continues, I guess, to happen, the way it happened initially, so we started teaching co-op to people. And, people in the workshops would be, people who work with kids with DCD, but they might work with younger kids than were in our studies, or they might work with older kids than were in our studies, or they might work with not DCD, but, straight learning disabilities, or not DCD, but ABI or whatever. And so inevitably at a workshop, a few people would come up to me and would say, what about this? What about if the kids were younger? Because our initial kids, because we were doing cognition, so Piaget, says 7 is the age of cognition. So we stayed 7 and up. And having said the thing about Piaget, every decision we made about how co-op would work came from a theoretical perspective, right? So for example, the reason we went with 7-year-olds is because, Piaget says 7 for cognition, so we went with 7-year-olds. So people say, what about younger kids, or what about this, or what about that? So pretty much all of those additional populations came because somebody said, what about? And I said, I don't know, but we could do a study. So that would have been the path. But now there are many, many studies that happen out there around co-op that have nothing to do with us. That it's another group of people looking at the approach, trying it out, and seeing where it goes.
Yeah. Yeah, the study that we're looking at today is the perfect example of that, where it's out of Sweden with kids with cerebral palsy. As you look at this study, what stands out to you from as far as the takeaways?
Right. So the thing that's it, well, first of all, just full disclosure, 2 of the, or maybe 3, but some of the authors of that study, in fact, are certified co-op instructors. So they're known to me. We know they're known to all of us in the co-op world. So that's one thing that just, to be clear on. So with respect to that group, the cerebral palsy group is a group where theoretically, if you understand what CP is supposed to be about or is about, then you would say a co-op approach or cognitive orientation would not work, right? Because it is a clear motor system dysfunction. DCD is not. DCD is as much about executive function and cognition as it is about motor. So moving DCD kids forward makes sense. CP, the first time somebody approached me around a CP study, again, it was students of mine, I said, we'll try it, but get your Kleenex out because it can't work. And, it was a master's thesis, so that's okay if it fails. And the reason I said it can't work is because if you think about something like tremor or spasticity, or if you think about something like a hemiplegia, that's not cognitive. Like that doesn't come from, cortex. So it really, theoretically, at least from my understanding at the time, it shouldn't work. What I hadn't realized until we started doing the work is that kids with cerebral palsy, in that first study that we did with kids with CP, is that kids with CP, because everything is done for them so much, and because everybody's focused on, passive movement and range of motion and stretching and all of those things, they actually have no personal experience of movement, of motor. So the first little child we worked with, for example, her goal was to be able to brush her hair independently. And she actually, so we in co-op, we always start with the baseline. So we hand her a brush and we say, do your thing. And she didn't even know the part of the brush to hold. So when she picked up the brush, she picked it up by the bristles so that the bristles are sticking in the palm of her hand, right? I'm thinking, oh my God, hasn't anybody ever even tried to teach this child how to brush her hair? And of course the answer is no, because she's got all these problems and we're going to brush her hair for her. So I think the reason co-op or a cognitive perspective does work with cerebral palsy and spina bifida, for example, is because every task that we do, any performance that we do has not everyone, like mental arithmetic doesn't, but most tasks that we do have a motor piece to them. And we're all kind of aware of that. And as OTs, we talk about the sensory motor piece of it. So, you have to feel the cup, you have to get your hand around the cup. So we see this as a sensory motor activity, but it's also a cognitive activity and it's also a learned activity. And so as OTs, what we've been focusing on is dealing with that sensory motor piece, but we don't deal with the cognition piece. So what co-op does is it brings cognition into the mix. And that's why it can work even with something like CP. Spina bifida was the big one. That was the one everybody was worrying about when that study was done, when that study was planned. Because because I don't know much about spina bifida, I think of spina bifida as a physical disability, right? That there's something physical going on. In fact, people who work with people with spina bifida a lot say the big problem for spina bifida is initiation of a task. Once they initiate a task, they're fine, but initiating the task is difficult. So, for example, in this study in Sweden, there was a young woman, about 25 or so, with spina bifida, who wanted to do self-catheterization. And so, as often happens, they phone me up and they say, Helen, self-catheterization, how do we do that? Because it's so unusual. And I'm thinking, I don't even know how to catheterize. I have no idea I know what it's about, but I don't know how to do it. And they say, no, that's not the problem. She knows how to do it. The problem is she never initiates. So her mom has to come and go over to her apartment and do it because she can never initiate. And so the problem with her with self-catheterization was not the mechanics of doing it. It was with self-initiation. And when they started working on it within the co-op within the co-op approach, what she said was, and don't tell me to set a timer and don't tell me to put it on my personal, because I've tried all of those, none of those work. So let's figure out a new way of doing it. And they did. And what they did, and it was her, of course, because that's how co-op works, she figured out that if she could tie it to an event that happens to her every day, no matter what, that it happens anyway, if she could tie self-catheterization to that event, then life would be good. So she tied it to breakfast, and she tied it to lunch, and she tied it to dinner, because she never forgets to have breakfast, she never forgets to have lunch, and she never forgets to have dinner. So she ties it to all that, and then the problem was solved. Except on the weekends, because she doesn't have lunch and dinner at regular times on the weekend. So then we had to she tied it to something. She tied it to lunch, to breakfast still on the weekend, and then, I can't remember it now, but she had to tie it to something different, or I think she decided that she would definitely have lunch on weekends and try and keep that routine. But for her, the issue was not at all what we as therapists might predict, and as I had predicted. It had nothing to do with the actual act of self-catheterization.
I just love this approach because it puts our clients at the center, and it acknowledges that there are all these complexities that they're dealing with that we as therapists just can't take in the short time that we know them. We really need to rely on our patients, our clients, to set those goals and think of what would work for them, and try it. There's multiple parts about the approach I want to talk about, and why those parts work. And I think I want to start just big picture with the focus on performance. I think as OTs, even though we talk about occupation-based practice all the time, our inclination is to go to the body level. And so my question is, could you speak to why this focusing on performance works? I think we're primed to hear that, but I think we need to hear it because that is not where we spend most of our time.
Right. So for most of us, and since we're on a technology right now, so for example, for most of us, we can use our computers, we can do whatever, and then suddenly there's a problem. So there's a breakdown, not in the computer, but in something that we do. And then then we're stuck. We don't know what to do next. And then we call the IT guy, and the IT guy says, push this button or something very, very simple, and suddenly everything's good again, right? Well, performance is like that in general. So most of the people that we see that, come to us for interventions, they know quite a bit around the performance of the thing. Something about the performance is not working. We as OTs and the physios and others do this as well. We as OTs, we look at the thing and we go, a visual perceptual problem or a figure ground problem or a coordination problem or a balance problem. And we think that we're going to go underneath it, right? So we're thinking we're going to go underneath it and we're going to fix that underneath thing. But if you think about most of our clients, they can do other things that actually require the very same skills, right? Because even if you think about, picking a pencil off my table, that requires figure ground, that requires perception, that requires visual input. So the fact that these underlying components are there or not there, when we look at a performance problem, we go to those components and we figure that's what's wrong, it's the underlying component. But often, in fact, I would say most of the, maybe even all of the time, that's not what's wrong. It's like the IT guy, we forgot that one button thing. So again, from this study that you're quoting from, another one of their clients was a young woman who was afraid to go outside. So she lived in her own apartment. She was homebound, totally homebound. And then the question was, and her goal was to be able to go outside. That was her goal. So when you start to think about be able to go, okay, so we start to think about anxiety and social fears, and I don't know, we start to think about a whole bunch of things, or, she's spina bifida, maybe she uses a wheelchair, or maybe she uses walkers and she can't get down this. Like we start to think of those kind of issues with co-op. With co-op, you don't worry about that. You say, let's talk about going outside, show me. So they go outside and they walk around and they're walking around and around because she's okay to go outside with others. She just won't go outside by herself. They walk around and the therapist notices that they've gone in basically a circle around a block 8 times, walked past the same parks several times. So the therapist says to her, is there a reason that we keep going past the same park? And she says, what park? So what happens was this girl, because of her walking problems or whatever, was so focused on walking, she only ever paid attention to sort of the 2-3 feet in front of her. She never looked at her surroundings. And of course, she is going to get lost every time because she's going in circles, or maybe not even, and she doesn't know where she is. So the solution for her was landmarks, was looking up, looking at the environment around you and making landmarks. And when she had that solution for her problem, she was fine. She had no more problem going outside, right? But if you're just the therapist and you're doing your typical sort of the activity analysis that we learned, and we don't actually observe the performance and see what's going wrong with the performance, you're never, ever going to guess. I'm sure none of the audience would have guessed if I had said, what do you think the problem is? I'm sure none of the audience would have guessed that the problem is that she looks down on the sidewalk all the time.
It's so powerful. I can see why it works. I'm curious, based on this study, has this expanded who you think co-op works for? And I guess the follow-up to that is, are there still populations that you feel like co-op isn't a good fit for?
I wouldn't use the word population per se, because I think it's individual characteristics. So for example, if you say, does co-op work with stroke? Well, it's certainly been demonstrated that can be effective with people with stroke. But are there people with stroke for whom co-op would not work? My guess is it would be people with severe depression, right? Because if you're severely depressed, you're not going to goal set. So how do we get you to goal set?
Yeah, that makes a lot of sense to me. I can see co-op working with so many of our clients, and the research has borne that out that has been published. but there is still the decision at the individual therapist level of looking at the client in front of us and thinking about some of these factors that you mentioned. Something that I wanted to be sure to ask about, and in my mind could be a barrier, is just people's expectations around what therapy is. I think we assume that I'm going to go see a therapist, they're going to do all this work, they're the experts. And co-op is great because it puts the client in the driver's seat. But have you seen that as something that subverts people's expectations, or that you've had pushback to where it really is so client-driven? What's been the response to that?
Yeah. So with kids, and remember we started with kids and I'm a pediatric therapist. So with kids, we don't see that. I mean, kids love being in the driver's seat. Kids love, they're going to set the goal and we're going to work on that goal together. And with kids, we make it fun. It's a mystery club. It's a detective club, whatever. And we're going to solve those performance issues and we're going to go out there and figure out what's wrong with it and how it works. So with kids, it hasn't been an issue at all, actually. It has from time to time been with parents, because parents want to bring their child to you, want you to fix their kid and then, hand it back perfect. So it is a matter of educating the parents. What is performance about? What is goal setting about? Why does the child get to choose their own goals? And, negotiating with that around the parents. And understanding what we're doing, that we're actually, yes, for sure, we're working on the goals that the client sets, but we're actually working on their ability to use cognitive strategies. to use cognitive strategies to perform tasks, because we're not going to be there to teach them each and every task. So we talk about the fact that, performance is cognitive based, that performance is about problem solving. And so we explain why we use the co-op approach. Where it's been a bigger issue, and that was a surprise to me, there's lots of surprises, but that was a surprise to me, is with adult patients who've been in rehab. So an adult patient who's been in rehab is used to walking in, the therapist, does the laying on of the hands or whatever the therapist does, and then says, okay, so this is it. We have to, strengthen this muscle, or you have to, learn how to move this way or whatever. And then we go into teaching them or showing them or even passively doing whatever the therapies we have. And many of our therapies, as you know, are quite passive. So when you go in and you say, no, so we're going to do it differently today. We're going to use co-op, and you're going to identify your performance problems, and with my help, but you're going to identify them and you're going to figure out what to do about them. And they say, okay, well, let's try that. And then the first time something happens and they're actually saying, and you say to them, so what are you going to do now? They say, well, you tell me, you're the therapist, you're the expert. Right? Like, isn't that your job? That's what you get paid for. Like, some of them actually say that. Don't you get paid for that? Why are you asking me? So this has to do with how you introduce co-op to them in the first place, and why are we doing it this way? What is this about? And that's when you talk about the fact that performance is very individualistic. Let's say they happen to be a sport guy. And then you can talk about how all the great sport players, like, Tiger Woods or Wayne Gretzky or whoever your favorite sport player is, they are always famous because they have a very unique way of doing whatever. Well, the thing is, we all have a unique way of doing whatever. Your hands are shorter or longer, your fingers are thinner or fatter, your knuckles bend more or less, and based on that, you're going to hold a cup differently, you're going to write differently, you're going to do it differently, and you're the expert in your occupation. So I could give you ideas, you might say to the client, I can give you ideas of what I've seen other people do or what could work, but we're going to talk about what works for you and what fits into your lifestyle, for example. And we all know that as soon as you offer a friend advice about what they should do, they'll tell you why they shouldn't do that, right? They have a lot of answers to why that's not the right answer. So in co-op, we try to avoid that. We try to avoid I'm going to tell you what to do and you're going to tell me why it won't work. We're just going to go straight to, let's see what you think would work. Like the young woman with spina bifida and self-catheterization who said, and don't tell me to set a timer and don't tell me to do this, because that's what they've always told me and that doesn't work.
What about the discomfort of sitting in the trial and error process, both for the client and for the therapist? literally in OT school, I learned the phrase, set the client up for success.
Very bad.
Yeah, which sounds really nice and makes for pleasant sessions, but totally contradicts the neuroscience that we now know, and we now know what works. How do we get past that desire as therapists? And in your experience, do people struggle with the trial and error process and that it subverts their expectation of what a therapy process should be like?
So the people who have a hard time with it predominantly are the parents who don't want to see their child struggle. That they just want to do it for them and fix it for them. So parents often have a hard time with that. And again, this would have required that you had very clearly explained what co-op is about and what the power of the struggle is, basically. So Dweck talks about the not yet phenomena, right? And that you have to struggle to learn. And as you said, from the goal setting literature, from the neuroscience literature, we have to, you know that there has to be a challenge to the activity. Otherwise, it's not going to fix the neuroplasticity. So we need the struggle. So in the co-op approach, we use a form of instruction called guided discovery. And it's the therapist's job to make sure that the child or the client is challenged, but not too challenged. So that, Csikszentmihalyi talks about his zones, right? So you want to make sure that wherever you're taking the client next in terms of solving the performance problem is present some issues for him, but not too many, or for her, and not too many. So your job is to be very, very attuned to what they're doing, what they're saying, and do your questioning, your commentary around that. So generally speaking, in co-op, we start with fairly broad questions. So something happens and we say, what happened? What didn't work? What went wrong? And often, particularly kids, will say, I don't know. And often the client will say, I don't know, because obviously if they did know what went wrong, they would have already tried to fix it. So they don't know what went wrong, but they pretty much always know it went wrong. So then we start to look at smaller and smaller questions about what went wrong. So for example, you think about a child, I'm thinking about a CP child who's trying to put on her socks and she can't put her socks on, they get stuck. So what went wrong? I don't know. It didn't work. Okay. Well, what part didn't work? Well, I don't know. It just didn't work. Okay. Where were you pulling? Oh, I was pulling at the top. Okay. And so I'm thinking of a particular incident, by the way, where the child is trying to pull on her sock and she's got her sock like this. So the little toe is out of the sock. And she's trying to pull on her sock, and no matter how hard she pulls, of course, the sock is not going anywhere, right? So where were you pulling? I was pulling at the top of the sock. Were you pulling really hard? Yeah, I was pulling very hard. What's your little toe doing? Where's your little toe? Oh, in goes the little toe, and it works, right? So that's the form of narrowing the question. So then what's the next plan? The plan becomes, so the plan is not pulling or pulling from the top or pulling hard. The plan for how to put on your socks then is make sure all the toes are in. And once we make sure all the toes are in, we're good to go. So then you would say, that's great. So how are you going to put on your socks now? I'm going to make sure all my toes are in. Great. How are you going to put on your socks? Again, it's a broad question, right? So we go to a narrow question, we figure out the solution, and then we go back to the broader question. And that's the guided discovery process, is making sure that whatever is, that you're drawing the person's attention to it. And because they do that, and because it's their answer, get all my toes in, they're feeling very, very successful. I remember one of our first kids, when he was writing his paper and he was beginning to stabilize the paper, and you can imagine his teachers, his therapists, everybody's been telling him to stabilize his paper for I don't know how long, but he didn't. And then he figured out that he needs to stabilize his paper, and that the way to do it is to use this helper hand. And then from a co-op perspective, you say, okay, so the helper hand, and generally speaking, you're working about generalization and transfer. So from a co-op perspective, you'd say, okay, so helper hand. So you're gonna tell me again how you're gonna use the helper hand. Well, I'm just gonna put my hand on the paper. And okay, so what happens if you forget that helper hand? And the kid goes like, Helen, you never forget your hand. Oh, like you can't leave it at home or anything? Helen, right? Okay. So now we have a helper hand, and this helper hand is going to do whatever. He runs out of the therapy room, and because his parents were well cued, he runs out of the therapy room. He says, guess what, Mom? I have a helper hand. And the mom's excited because you have a helper hand, and he's excited because he has a helper hand. And his homework is to figure out 5 other things that he can do using his helper hand. 5 other things to have a helper hand. And that's the part of generalization and transfer of co-op, right? And then his other piece of his homework was to find out if everybody in his family has a helper hand. And what he discovered was his brother didn't. Now, remember, DCD tends to run in families, so it's not unlikely that the brother doesn't have a helper hand. So his brother didn't, and what I thought was really cute at this kid, he says, "And I'm not going to tell him about it."
Oh, I love hearing about how focused we get to be on the client in front of us in this approach. It feels so different than I think about my own treatments, where I would come in with this plan. I would feel stressed because I would be like, oh my goodness, I have to make this plan for the session before I go in. And it feels like such a totally different kind of therapy to be like, I'm going into this in armed with questions and really paying attention to what's going on in this totally different framework. Do you find that therapists thrive in this slightly different role? I'm like, in some ways it's so foundational OT, but it's a different way of doing it.
Yeah, so some therapists are naturals at it, actually almost don't even have to teach them much about it.
Yeah.
Right?
I can see that.
I mean, that's what they do. Some therapists, this is very foreign for them, and they have a really, really, really hard time with it. So the co-op approach, the DPA, which is the dynamic performance analysis, which is where we figure out, that I've left the little toe out or whatever it is I've left out. That DPA part is also hard because even though we think we're really good at activity analysis, we're not good at performance analysis. We're not good at figuring out exactly what went wrong there. So there's a clip that we use in the workshop where there's a sort of a 15-year-old Italian boy with very, very spastic kind of hands. And he wants to be able to open a bottle cap by himself. And he takes the bottle cap and he's twisting and he's turning, and then he keeps changing his hands on where he's twisting and he's turning, and he's going like this and he's going like that, and can't get the bottle cap off, right? And you say to therapists, so what's going wrong here? Where's the breakdown? And they talk about stabilization of the bottle. They talk about grip strength. They talk about, fine motor dexterity, like all of these things. What's wrong is he doesn't understand that you don't hold the whole cap, that you only hold the top of the cap, because there's this little ring and you have to break that seal. Once you break that seal, you're good. So this young man, he does this. We do 2 or 3 trials of co-op with him, so what's going wrong? What are we doing? Where are you putting your fingers? How much are you holding? Is there one thing to hold? Are there 2 things to hold? Tell us what's happening. And within, 10 minutes or something, he's able to open any bottle cap, right? And that's nothing to do with strengthening, and it has nothing to do with visual perception. It has nothing to do with stabilization of the bottle. It has nothing to do with any of those things. It has to do with his understanding of the task requirements. So that's easy for some therapists. They're really good at it. For some therapists, it's such a different way of thinking, and they just can't get around the fact that they're not going to do strengthening first, because that's the problem here, is strengthening. So for some therapists, it's easy. For some, it's very, very difficult. And we talked about prerequisites for co-op and which populations it might not work for. I think there's therapist prerequisites. And one of the therapist prerequisites is that you have to be comfortable with client-centeredness. You have to be comfortable with the client leading it. But you also have to be really good at very detailed observation of what's going wrong when performance happens, because that's how you know where to guide the discovery of the solution. So I don't think it is for all therapists. I think if you're really like a hand laying on of the hands, wonderful therapist, co-op might not be for you. You might hate it. But on the other hand, because co-op, you have these aha moments, and where the client is discovering something and they're very excited because it's their discovery. It's not you're the therapist, it's their discovery, and it has a major effect. When the client discovers something, that aha moment is so reinforcing for the therapist. And there are so many mini successes within the co-op session. Those are all very reinforcing for the client, success, but they're also very reinforcing for the therapist. So even some, really good what I call hands-on therapists, love the co-op approach. But there are certainly therapists who I think would not like it. because it makes them feel like what your questions have been alluding towards. It makes them feel like they're not doing anything, but the client is doing it. But it's that guided discovery and that therapist CPA. Co-op sounds easy. You just ask a bunch of cool questions and the client figures out all the answers. Co-op is a huge cognitive load. It's a huge mental load because you're always watching and you have to give up on where you were going. So you thought you were going to go lead it there. And then if you're paying attention, the client is actually giving you a clue as to where to lead it. And you have to pay attention. So it's hugely cognitively intense for therapists. You're actually quite tired at the end of a co-op session, even though mostly just been sitting and talking.
Yeah. Yeah, that's helpful for you to hear out or for you to say out loud, because I think that reinforces some of the assumptions I was making where I was like, this sounds really fun, but it sounds like a skill set that would take time to develop. That's because it's different than what I've done historically. But I think all the things we've talked about today inspire me, though, for I think it will help people reflect on their own practice, whether or not they're a co-op trained therapist. It lets them know there's other ways out there. I think we all hit times where we feel stuck. We're at our last question already. I've heard you talk about the Olympic spirit before. I was wondering if you could tell us about that.
Yeah. So earlier you were saying something about, what we do within sessions and whether we see improvement or don't see improvement. And I think most of us as therapists, we're there because we want our clients to get better. I've never met therapists who are there because they're getting a paycheck or because, they chose the profession to make money. That's not why we do, right? We do what we do because we care about our clients and we want our clients to get better. And generally speaking, while they're with us, they do, right? So because we start building relationships, we have small successes with the clients, they do get better. The question is, are they getting better as much as they could? And the question is, are they getting better because of what I'm doing from an intervention perspective, or are they getting better because we're becoming friends and we're working better together, right? So from an intervention perspective, you have to know that the active ingredient here is not you, the therapist. Maybe you're part of it for sure. In co-op, you definitely are, but it's also these other things that you're doing. So what I would challenge therapists to do always is think about, even if you think you're doing well, think about, could I do this better? Could I do this faster? And that's what I refer to as the Olympic spirit, better, faster, higher. Can we achieve success faster? One of the impetus for making co-op be about 10 sessions is that the governments in Ontario, which pays for school health therapists, say we're cutting down from usually allowing a therapist to work with a client for 2 years at a time during the school year, break, and then school year again for second year. They cut it down to 10 hours. So if you got to think of what you used to do in 2 years and now you got 10 hours to do it, so co-op was designed to be a 10-hour intervention because that's what the government of Ontario was paying for at the time. So that is faster, higher, better, right? Because if we want to get the results, if we want our kids writing, we want our kids being able to ride their bicycle, whatever it is, those were always DCD kids, then you have to know how to get there really quickly and really effectively. So for me, that's what you should think about. So even if you think you're doing a great job, could you do faster? Could you do it better? Could your results be quicker? Could the improvement be a great deal more than what you've already done so far? So that's for me the Olympic spirit.
I've been so inspired by this conversation, and it gives me so many things to think about. I feel like from hosting this podcast, I've kind of been primed because we've been thinking about several components from different angles that we've talked about today. Like you said, the research just across fields, across neuroscience, across OT is showing us why these approaches are working, and there's definitely a common theme to them. But with all that we've talked about, my final question for you is, what's the final thought you want to leave us today? What's the final takeaway, do you think, for therapists?
I think the final takeaway for therapists is that ultimately, as OTs, because we're concerned with what people do with their occupation, if you're comfortable using that term, or their activity, if you prefer that term, because what we care ultimately is that people experience success in what they want to do, need to do, or expect to do. Our job is to figure out how to guide that to happen. And in most cases, we can't fix our clients. It's just not possible. We don't know how to fix depression. We don't know how to fix schizophrenia. We don't know how to fix DCD. We don't know how to fix cerebral palsy. We don't know how to fix any of those kinds of things. And because we don't know how to fix them, then we need to learn how to work with what's possible. And by the way, even if they were fixed, they still wouldn't necessarily be able to do a skill. I'm fixed. I've never had a stroke, thank God. I don't have a particular physical disability of any kind. I can't roller skate. I can't play piano, right? So just because you're fixed doesn't mean you've got the skill, because one of the important things to always remember from an OT perspective is that skill performance is part. So, in psychology, we talk about necessary and sufficient conditions. So for you to perform, for me to lift up this cup, it is necessary, 1, that I have a cup, and 2, that I have a hand, and 3, that I'm motivated to lift up the cup. And then that I have the ability to lift up the cup, and then I have the skill. I know how to separate my hand. I can move my hand. So it's not that any skill requires a combination of all of those things. And as OTs, sadly, we're trained to think about the sensory motor piece almost exclusively. And we're not trained to think about all those other pieces that are just as important, if not more important. So the physical ability to pick up a cup, the physical ability to open and close my hand, and to, gauge the amount of strength or pressure I put on the cup, that physical ability is part of it, but it's not a sufficient condition. So some of the things that we look for when we look at component analysis we might think they're necessary conditions, but they aren't sufficient conditions. And what we have to look at is, so what are the sufficient conditions? I know in pediatric OT and handwriting, one of the things that OTs always talk about is, being well positioned in the chair, having the chair be the right height, having the table be the right height, having the paper positioned at the right angle, having the right pen and the right grip, and all of these things we think are necessary. They're not, nor are they sufficient, right? Because you walk into kindergarten, your room, and you see kids lying on their belly with crayons, writing. Right? So what happened to fitting out a chair, 90 degree, right? These are not necessary conditions. A lot of the things that we as OTs, unfortunately, were taught were necessary conditions, in fact, are not. And clearly, they're never sufficient conditions. So work for what's necessary, but also focus on what's sufficient. I guess my final word.
Yeah. Well, Helen, thank you so much for all that you've shared today and for the work you've done. It's been such an honor to talk to you. This is an approach I've been following for years. So it's, just an honor to be able to hear the story of it and hear how you're thinking about it currently. Thank you for the time today.
Well, thank you for the interest. And thank you, as I said at the outset, for trying to make sure that OTs becomes an ever better profession. So I would say you have the Olympic spirit around OT.
Oh, well, thank you. Wow, you all, it was such an honor to hear from Dr. Polatajko today. This approach to OT is a big paradigm shift for many of us, but I also hope that this conversation left you with practical ideas for involving your clients in the goal setting and treatment process. This may be as simple as asking more reflective questions, like, how do you think that went, or what went wrong? I encourage you to let us know your thoughts and your questions in the comment section on YouTube or within the OT Potential Club. The OT Potential Club is also where you will go to earn a certificate for your time today. All you have to do is head to otpotential.com and either sign in or sign up for the OT Potential Club. It is currently only $89 to have access to our many courses and resources in the club. So if you are not yet a member, I highly encourage you to join us in there. And as always, I want to thank you so much for joining us today. I hope this podcast helps keep you informed and inspired as an OT professional. Take care, and we'll talk next time.